Hello, my name is Teshamae Monteith from the University of Miami and Assistant Professor of Clinical Neurology. And we will be interviewing Dr. Richard Lipton. He's Vice Chair at Neurology at the Albert Einstein College of Medicine and Director of the Montefiore Headache Center. He's a Professor of Population Health and Epidemiology, a Professor of Psychiatry and Behavioral Sciences. He's published over 600 peer-reviewed journals and 10 books. He was a prior American Headache Society president and is chair of the Chronic Migraine Medical Education Program. How are you, Dr. Lipton?
I'm great. Thank you for that very generous introduction.
You've done so much for the field, so thank you. And you also gave us a wonderful review of migraine for Plenary in Review. Can you tell us about 3 areas?
Yeah, so of course, reviewing what's happened in headache medicine when there are thousands of papers in any given year is a bit of a challenge. So I focused on 3 areas. One of them was neuromodulation, highlighting a study of vagal nerve stimulation in cluster headache. One of them was the natural history of migraine and predictors of headache progression. And then the final area I talked about was the role of CGRP in migraine, both small molecule therapies and monoclonal antibodies, which are emerging treatments.
So there's been a lot of wonderful advances. What can you highlight for us that we can understand a little bit better about migraine that we can then take into the clinics for the listening neurologists?
Sure. Well, so in the area of neuromodulation, there are currently 2 FDA-approved neuromodulatory devices for migraine. One of them is transcranial magnetic stimulation, and that is FDA-approved as an acute treatment for migraine with aura. In those studies, after aura began, patients were instructed to apply a device that delivered 2 magnetic pulses to occipital cortex, and the active device was shown to improve pain-free rates relative to the sham device. There's since been open-label studies showing that repeated use of transcranial magnetic stimulation appears to reduce headache frequency as well, supporting that theme that maybe the distinction between acute and preventive therapies is not so great as we once thought that it was. The other FDA-approved device is called the Cephaly device. It is a transcranial electrical nerve stimulation device where stimulation is applied to the supraorbital nerves. And that device is FDA-approved for migraine prevention, shown to be an effective migraine preventive therapy in a double-blind study done by Jean Chernin that was recently published in Neurology. But the reality is that that device, too, is used in practice as an acute treatment and not as a preventive treatment, again, supporting that theme.
Okay. Some of your other findings from the AMPP suggest that we need to do a better job of treating acute and preventive for migraine. So do you think some of these new advances will help us in terms of compliance and adherence?
Well, so, you know, I think what one of the things the AMPP teaches us on the population level is something that I think everyone who treats headache patients knows, which is that there's a subgroup of people who start out with episodic migraine, just a few headaches per week or month, and over a period of time gradually progress to the point that they're having headaches more days than not, or maybe even headaches on a daily basis. And in our population studies, we show that 2.5% of people with episodic migraine progress to chronic migraine on an annual basis, and we show that progression is associated with a number of risk factors. So there are headache-related factors associated with progression. The number of headache days a person experiences per month is itself a predictor. Persistent frequent nausea is a predictor. Allodynia is a predictor. We show that comorbidities are predictors of headache progression. We show that a number of aspects of treatment are predictors of progression. So using opioid or barbiturate-containing analgesics predicts the development of chronic migraine in people who have episodic migraine, and people who don't respond well to their usual acute treatments are also more likely to progress. So the suggestion would be that these are all factors that could be targeted therapeutically, though I want to emphasize that the appropriate studies haven't been done showing that we can modify natural history. I think that's an urgent priority for the field. But in the meantime, I think neuromodulatory devices, as far as we know, don't contribute to headache progression and may provide an alternative to the overused medications that do contribute to progression. And if these therapies decrease headache frequency and severity, that too could have a positive long-term effect.
So what's the next step?
Well, gosh.
I'm sorry.
No. I mean, the next step really is to design studies where we identify people at high risk for progression and intervene in selected risk factors to see if we can modify natural history. There's only been one study, as far as I know, that's attempted to do that. That study, a study called Intrepid, which was a randomized trial where people with 10 to 14 headache days a month were treated with topiramate, and the primary endpoint in that study was to reduce the onset of chronic migraine. The study was discontinued prematurely by its sponsor, and there were non-significant trends suggesting that preventive treatment worked to reduce the risk of chronic migraine onset. The study was positive in showing a reduction in headache days in the group that got active treatment versus placebo, but did not show a significant difference in rates of progression, though I found the trend encouraging. And honestly, what I think we need to do is define high-risk groups using a multiplicity of risk factors and not just one.
So some of the other plenary speakers spoke about large data sets. How would that help migraine and moving the field forward?
Yeah, so what large data means is highly variable. So, the AMPP study screened 163,000 people, and we identified a target sample of 24,000 severe headache sufferers who we followed. So in some sense, that's large data. In a clinical research context, a lot of times when people talk about large data, what they mean is using medical claims and pharmacy data and linking that to genomics or high-dimensional neuroimaging data. And the problem with using electronic health record approaches to migraine is migraine remains highly under-ascertained. So lots of people with migraine don't have a migraine-specific diagnosis and medical claims data. And if you go into a large population and directly interview health plan members and then look at who has a migraine diagnostic code, it's only about a third. And then if you try to do everything you can to find everyone with migraine in the plan and you use triptan use, preventive medication use, psychiatric comorbidities, you can still only find about 60% of the migraineurs. So under-ascertainment in administrative data is one of the big limitations to using that particular brand of large data approach.
Exciting. Thank you so much. I want you to catch your plane.
All right. Great.